I want to record a quick overview of syncope, the pathogenesis, etiology, and workup. If you want something more in-depth, I recorded an 1.5-hour talk that will have a link down in the comments. To give you sort of the big picture, we're talking about something that deals with being unconscious. And when you're dealing with unconscious, you have a couple of possibilities. You are either unconscious because you want to be, you're voluntarily unconscious, or the unconsciousness is involuntary. Or you might say involuntary. So if it's not voluntary, if it's voluntary, it's like I went to sleep at night like I'm supposed to, it's physiological. If it's involuntary or involuntary, it's either permanent or temporary. So let's call the loss of consciousness that is involuntary, let's call this loss of consciousness. This is a loss of consciousness if it's involuntary. And if it's permanent, we call that coma. And if it's temporary, we call it a transient loss of consciousness, often abbreviated TLOC. For the differential of transient loss of consciousness, syncope is part of this differential, but it's not the only thing that causes a transient loss of consciousness. The thing you need to remember is the mnemonic mattress. The M in this mnemonic stands for metabolic, so metabolic. This would include things like hypoglycemia. It can include things like hepatic encephalopathy. Anything that goes on inside of the body that affects the brain globally and causes a loss of consciousness. The A, representing anaphylaxis, is actually a subpart of T, which is toxins. Anaphylactoid toxins are one kind of toxin, but there are many kinds of toxins that can cause unconsciousness. For example, opiates are a toxin, they're a drug. Other things include poisons. Trauma can be a little bit tricky because when you have a trauma, you hit your head, you can lose consciousness from that trauma. The other thing is, if you're standing upright and you lose consciousness for any reason, it can cause a trauma. So for anybody that has a transient loss of consciousness, regardless of what you think the cause might be, the first thing you ask yourself is there any head injury? If there is, then the second thing you have to ask yourself is, did this unconsciousness cause the trauma, or did the trauma cause the unconsciousness? The R stands for ridiculous, and by ridiculous I mean psychogenic. I'm not saying people who have psychogenic syncope are ridiculous. I'm saying that it looks ridiculous. Next we have the E. E stands for exhaustion. Typically when you have exhaustion, the transient loss will be a prolonged transient loss of consciousness. The person will be arousable, so you can wake them up with a sternal chest rub and things like that, whereas in other causes of unconsciousness, for example with toxins typically, you will not be able to wake them up. Also with exhaustion, you're more likely to have a voluntary loss of consciousness, going to sleep, rather than a loss of consciousness where you fall asleep. I know this from experience. I was in boot camp, and in boot camp we were so sleep deprived that we actually learned how to march asleep. We would be somewhere in between conscious and unconscious, walking down the street, waking up as we arrive at wherever we're going, realizing we have no idea how we got there. That was Navy boot camp back in 2003. As I understand, since then they've changed everything around so that you don't even have to leave the building to do the entirety of boot camp. I could be wrong about that though. Next on the list we have our S, which is seizure. When you have a seizure, it can cause a loss of consciousness. However, when you have syncope, you can also have a loss of consciousness with myoclonic jerking. However, here's the difference. Here's how you tell the two apart. With seizure, the myoclonic jerking occurs before the loss of consciousness, and with syncope, the jerking and spasmodic movement happens after the loss of consciousness. And then last is syncope. So you have MATTRESS, or mattress. And that is your differential diagnosis for a transient loss of consciousness. Now, I spent a lot of time making this mnemonic. I hope it helps somebody. In fact, I had to add a anaphylaxis to make the mnemonic work, but it is a subtype of toxin, so even though anaphylaxis is rarely a cause of loss of consciousness, it can be in some situations, and it fits the mnemonic. Now, when you're working these up, for example, metabolic causes, you're going to look at things like metabolic diseases. You're going to check their blood sugar. You're going to check things like that. And the history is going to be suggestive. For toxins, you're going to say, is there an exposure? For trauma, you're going to see an injury. For psychogenic, it's going to look a little bit ridiculous. For exhaustion, you'll have a history of sleep deprivation. And with seizures, you can differentiate this because with seizures, there's two things that really you'll see. You'll see incontinence. It can be urinary and fecal incontinence. So if a person is urinated on themselves or pooped on themselves, it is more likely to be seizure than syncope. And the other thing is, when did the jerking occur? Did it happen before the loss or after the loss of consciousness? Now, it's good to start off with a definition. What exactly is syncope? We know it's a transient loss of consciousness. Something that will differentiate it from most of the other things in the differential is the timing. It usually lasts less than 2 minutes. So less than 2 minutes. Usually on average it's between 1 to 2 minutes long. Rarely will it ever be longer than 2 minutes. The second thing is what causes it. It is caused by the failure to deliver nutrients cerebrally to the entirety of the brain. So it's inadequate delivery of cerebral nutrients, to the brain due to cerebral hypoperfusion. This hypoperfusion usually lasts between 8 to 10 seconds. So even though the unconsciousness is going to be 1 to 2 minutes, the hypoperfusion, the event that causes it, lasts 8 to 10 seconds. The other thing is it must be completely reversible. So we distinguish it from a stroke because of two things. The first thing is it is not a focal loss of delivery, it is a global. And the second thing, it is a completely reversible. It is also distinguished from a TIA, which is completely reversible, because in this situation, again, it is not focal, it is global. So not only is the loss of consciousness transient, but the hypoperfusion is also transient. Now, when you're talking about syncope, you'll also hear the word presyncope. What is presyncope and how is it different? Does it happen before every kind of syncopal episode? The answer is no. Presyncope you can replace with the word prodrome. Prodrome of what? This is the prodrome that typically happens before a loss of consciousness. Certain kinds of syncope will typically have a prodrome, and other kinds typically won't. So the prodrome consists of lightheadedness with sweating. You get tunnel vision or a change in vision. So I'm just starting from the top. Lightheaded at the very top, sweat on the brow, vision starts to change. You start to feel warm, and you can lose a little bit of your hearing at times or hear a whooshing noise. There's also a little bit of nausea or GI discomfort. You may or may not get palpitations, and people who see you will describe pallor. Sometimes these prodromes occur with some kind of sense of fear or panic or doom. And now I actually hope that the listeners, watchers of this video like Sketchy Medical. Sketchy Medical is a group. They've done a series called Sketchy Micro, Sketchy Farm, Sketchy Path, and they use drawings to help you to remember certain aspects of it. And now they do really good illustrated, animated drawings. I'm not going to do that, but I did make you guys a sketchy. In order to help you remember presyncope, I borrowed from Randy Rowe, who made the balloon-headed guy, the red balloon-headed guy, and I altered that myself. And so you can see that the balloon represents the lightheadedness, the diaphoresis is over here with the sweating, the blurry or tunnel vision represented by the tunneled eyes, the warmth represented by the redness itself, the decrease in hearing or whooshing represented by the hands over the ears, the GI discomfort by the nausea or the vomiting coming out of his mouth, palpitations, and then you have, of course, other things such as GI discomfort. And so if you ever need to remember syncope, just remember this picture, pre-syncope. You'll remember what it looks like, at least. But what you need to know is presyncope is not only caused by the things that bring on a syncopal episode. In fact, half of the causes of syncope do not have presyncope typically. So where else would you also see presyncope? You can see presyncope with hypoglycemia. You can see presyncope with panic attack. These are simply just prodromes caused by an outflow of the sympathetic nervous system. Your sympathetic nervous system senses something is wrong. Typically that something wrong is hypoperfusion, and it says, okay, sympathetic nervous system, outflow, clench down on everything, heart starts pounding, you start sweating, everything goes crazy, and that is presyncope. It is sympathetic outflow, and you see it in a number of situations. And just for repetition, I made this into a slide for you. We've already talked about it, the differential diagnosis for a transient loss of consciousness, and we're going to focus on syncope. With metabolic, you'll usually see something lasting greater than 2 minutes. You'll see a metabolic disturbance, for example, acidosis or hypoglycemia. With a toxin, greater than 2 minutes, a history of exposure. With trauma, you're going to have greater than 2 minutes typically with some kind of traumatic injury, bruise, laceration, etc. Psychogenic, the timing can be variable. It can be greater than 2 minutes. It could be 30 seconds. The point is the timing with psychogenic can be greater than 2 minutes as well. It usually will be recurrent several times within a 30-minute to an hour episode, and if you were to ever do EEG, I'm not saying that that's recommended, but if you were to do EEG, it would be absent of any loss of consciousness on the EEG. With exhaustion, you're going to have a history of sleep deprivation. In the physical exam, you'll see indicators of sleep deprivation. With seizures, you can see urinary and fecal incontinence. And then the timing of the myoclonic jerks are also going to indicate whether it was seizure or syncope. When you get down to the brass tacks, there are really two causes of syncope. There are the neuromuscular causes and the cardiovascular causes. Now, I use the word neuromuscular relatively liberally. It really would be autonomic nervous system dysfunction if you were to give this a better name. And with autonomic nervous dysfunction, you can have dysfunction in the sympathetic nervous system and dysfunction in the parasympathetic nervous system. So this is all on a balance. So what's the normal physiology? Let's say you're laying down and you happen to stand up. Immediately, you have about 1 liter, anywhere from 500 to 1,000 mils. It will go from the upper body into the lower body, so the legs, the lower pelvis, the abdomen. This will cause a decreased cardiac output. So the cardiac output drops off, which causes the baroreceptors in the pulmonary vasculature to go off. So you have baroreceptors. And these baroreceptors going off lead to immediate sympathetic activation. They cause vasoconstriction, and they also cause tachycardia. So you can increase the cardiac output. Now I say tachycardia, it's usually a slightly increased rate and a slightly higher inotropy. Now this will lead to a change in the systolic and the diastolic pressure. So what happens to each of them? Does the systolic or diastolic go up or down? What is the change? Now, the way you can remember this is you have vasoconstriction. Well, let me just tell you. So the systolic typically will drop between 5 to 10 millimeters of mercury. But the diastolic will increase 5 to 10 millimeters of mercury. So how are you going to remember which one falls and which one goes up? If you think about mean arterial pressure, so what is the equations or what is the math that usually uses this? What is the, how is it defined? So the mean arterial pressure, if you wanted to know what someone's MAP was, you would say that it is their diastolic pressure plus one third of the pulse pressure. Now, pulse pressure, you might remember, is defined as the systolic minus the diastolic, right? Minus the diastolic. So if you were to say what is exactly right in the middle of systolic and diastolic, you would say, I want to know what the diastolic is plus half of the pulse pressure. And if the mean arterial pressure were equally related to both the systolic and the diastolic, then your equation would say diastolic plus 1/2 of the pulse pressure. But it is not. It's actually 1/3 of the pulse pressure, because the mean arterial pressure, the cardiac cycle, you get your blood pressure shoots up and then it drops down and it slowly kind of drifts until the next shoot up, right? And so it stays closer to the diastolic pressure longer than it does the systolic pressure. So the mean arterial pressure is more related to diastolic than systolic. Well, if you might also remember that cardiac output is equal to the mean arterial pressure times the total peripheral resistance, or the peripheral vascular resistance. So when we're talking about vasoconstriction, we're talking about resistance, right? And when you get vasoconstriction, it's going to have a higher impact on the diastolic pressure than it does on the systolic pressure. So diastolic will go up. The other thing that will happen in normal physiology is that the heart rate, it will tend to increase between 10 to 25 beats per minute. And so if you have a failure of that sympathetic nervous system, if the sympathetic output drops off, then you can have syncope. Conversely, if you have an overactivation of the parasympathetic nervous system, you can also have syncope. This failure of sympathetic output we call orthostatic hypotension, abbreviated OH. And this abnormal increase in parasympathetic nervous system we call reflex syncope. So these, or sometimes it's called neurogenic syncope, sometimes it's called a few other various things, but the more modern definition would be reflex syncope. Reflex syncope, you may have heard of some of the subtypes, and we'll talk about these subtypes of reflex syncope, which includes vasovagal syncope. But for now, I'm just expanding on these two broad classes, the two causes of syncope. One would be autonomic nervous system, or neuro. The other one would be cardiac. And this cardiac side, we can also break down into various different, two different causes. So first we would have arrhythmia, and the other we would call structural. Or you might think of it as anatomic. So with arrhythmia and structural, we can define the two subclasses of cardiac or cardiovascular syncope. Now I say cardiovascular because not all of these are within the heart itself. A few of them are actually due to vasculature causes. And so within the neuro, we have reflex syncope and orthostatic, and we have cardiovascular, arrhythmogenic, and structural. The diagnosis, so for reflex syncope, you can only really diagnose that with history and tilt table to confirm. With the orthostatic, you can do tilt table, but really all you need to do is do orthostatic blood pressures as a really the primary clue. With cardiovascular, ECG or EKG, sometimes you may need electrophysiological studies. That's rarely needed. The other would be echo and CT for the structural causes. So real quickly, what is the definition of all of these things? So reflex syncope, it is a neural reflex that inappropriately decreases either the heart rate or the blood pressure. When it decreases the heart rate, it is called cardioinhibitory. When it decreases the blood pressure but not the heart rate, it is called vasodepressor. Orthostatic, it is going to be defined as syncope that occurs secondary to orthostatic hypotension. So for orthostatic syncope, you need orthostatic hypotension. Syncope that occurs secondary to an arrhythmia, obviously, and syncope that occurs secondary to cardiovascular or cardiopulmonary disease would be a structural syncope. And so here it all is. This is a parasympathetic outflow problem. This is a sympathetic failure. And then we have either tachyarrhythmia or bradyarrhythmia. Then last and all, but not least, with structural problems, it's either obstruction of flow, obstruction of prefill of the heart, or it can be vascular steal. First, let me say with the reflex syncope and the orthostatic syncope, I am simplifying these things quite a bit because Saying that this is only sympathetic and that this is only parasympathetic is sort of to just blow off a crap ton of literature that argues for various mechanisms. But the majority of the literature would somewhat or mostly agree with this paradigm. And so I'm keeping this simplified paradigm mostly for didactic purposes, because actually, whether it's sympathetic, parasympathetic, the failure of one specific ganglion or another is not really as important as in the initial part of this understanding as it is just to have a big picture overview. Now, two things I want to do based on this slide. The first thing is I want to say that when we're talking about presyncope, we are talking about a prodrome that is typically seen with reflex and orthostatic syncope. If it is the heart, you usually do not have a warning. The prodrome is a warning that something is about to happen, that you're about to pass out. If you have a warning, it's not from your heart. The heart happens without warning, and that's why it's so dangerous. The next thing I want to do is sort of clear some space and just basically explain why these four things cause syncope. First of all, you have to have blood flow to your brain. If you don't have blood flow to your brain, you die. And so what are the things that you can do to quantify the blood flow to your brain? It's called cerebral perfusion pressure, so CPP. And what is CPP? It is equal to the mean arterial pressure minus the intracranial pressure. So what can cause decrease of cerebral perfusion pressure? What can cause a global drop that is transient in the pressure? And that is anything that can cause a drop in the mean arterial pressure. Now, the normal intracranial pressure is between 5 to 15 millimeters of mercury. So in order to have adequate cerebral perfusion pressure, you need to have a mean arterial pressure that is greater than 60 to 65. The literature seems to indicate that if it's greater than 60 to 65, there are no problems. If it drops lower than 60, you start to get confusion. And this is if it drops lower than 60 for a prolonged period of time. If it's transient, typically you probably won't have a notice of it, or the notice will be very vague. Now, if it drops much further, then you get an inadequate cerebral perfusion, inadequate delivery of nutrients, and you get syncope. That is the pathophysiology of syncope. Now, while it's true that an increased intracranial pressure could also decrease the cerebral perfusion pressure, there are not many known causes of increased ICP that are transient. So because they're not really, as far as transient, meaning they occur in between 8 to 10 seconds, there aren't any ICP increases that contribute to the pathophys of syncope. Now, a higher ICP can make you more susceptible to the things that cause syncope, but in general, these would just be risk factors, and they're not really, they're not risk factors that are prevalent enough to even be on a risk factor scoring system. So just knowing this, it might help you catch some type of cryptogenic risk factor, but it's not really going to help most physicians that deal with syncope. Now, with that said, you have a big picture overview of syncope, and we're going to stop right here. If you want to know more about either the autonomic or neuro causes of syncope, that'll be the next video. And then the third video is going to be the cardiac or cardiovascular causes of syncope. And then there will be a final video where we talk about tilt table testing, and we also look at the guidelines on working these things up.